we manufacture various critical care products, lyophilized anti-cancer formulations, and hormonal tablets. And to do this, to market this, we have a team of 10 leading divisions in Samarth. Conquest is one of it, which markets the oncology products. So this was about us and about the program. So this is a digital platform wherein we have a series of meetings, and with these meetings, we are very much sure that this meeting, which we will be making live shortly, would also be attended by various delegates that should have and obviously have some good take-home messages from some scientific discussions. So that's what is our idea, and obviously that should has a better patient care. So, and for that we have good speakers which presents various topics. So today we have two topics which would be presented by our speakers for today. So the first topic would be about the role of Megestrol Acetate in anorexia and cachexia. That would be done by Dr. Fahad Afzal sir. And the second topic is on the current treatment options in HR positive and HER negative metastatic breast cancer, which would be and Dr. Asma would enlighten us on that. So let us begin, and with this, I welcome Dr. Fahad Afzal sir to have his topic, and it's my again honor to introduce sir. So sir is a consultant medical oncologist and hematologist at Jaslow Hospital, Mumbai. Yeah, his expertise is management of cancer of breast, colon, lung, prostate, ovary, stomach, head and neck, and autologous and allogeneic bone marrow transplant. Dr. Fahad has received certification of ESMO in medical oncology. Specialty certificate examination in medical oncology by Royal College of Physicians, and he is also a member of renowned societies like Indian Society of Medical and Pediatric Oncology, Immuno-Oncology, European Society of Medical Oncology, and Associate API India. And sir has various publications to his repute that are in good national and international journals. So with this, I welcome Dr. Fahad and request him to initiate his session. And following that, we'll call up Dr. Asma. Over to you, Dr. Fahad. Sir, you can start sharing the screen.
Thank you very much for the kind introduction. Let me just quickly share my screen. So is my slide visible?
Yes, sir.
Yeah. So thank you, Samarth. At the outset, I would like to thank Samarth for inviting me for this topic, which is very close to me because I do prescribe a lot of Megestrol, and I've seen the kind of results that this wonderful agent gives. Also, apologies for the delay. We were supposed to begin almost 45 minutes back, if I'm not wrong. So I'll be talking on the management of anorexia and cancer cachexia in general. So what is anorexia? It is the loss of the desire to eat, and it results because of changes in the smell or changes in the taste or any specific alterations of the taste, such as specifically meat aversion, early satiety, nausea, vomiting. All this will lead to loss of desire to eat. Anorexia may be a presenting complaint. The patient may present with loss of appetite or loss of desire to eat, but it may be associated also with a treatment for cancer, that is anti-neoplastic therapy. What is the pathogenesis? As we know, multifactorial, many factors can cause anorexia, and the central physiological mechanism eventually gets disturbed, which is responsible for the food intake, as we'll be seeing in our later slides. So in a normal condition, how much food we need to take is controlled by certain inhibitory signals that are present in the hypothalamus, which tells us about the energy status and the adiposity status. The arcuate nucleus, specifically in the hypothalamus, helps transduce this inputs into a neuronal response, and that by the second order neuronal cells gets translated to behavioral response. So anorexia is a problem involving the defective signals in the peripheral part, that is the second order neurons, or in the central part, that is the hypothalamus. So cancer anorexia in particular involves primarily the central part of this mechanism, that is in the hypothalamus. There are various cytokines that mediates this hypothalamic resistance, such as IL-1 or TNF. Also, it kind of disturbs the normal balance between orexigenic and anorexigenic signals, and end result is that the prophagic neurons, which are responsible for increasing the appetite, they get suppressed. So this beautiful slide shows us how in normal condition the balance is maintained between anorexigenic signals and prophagic signals. But in cancer, this gets disturbed because of increased serotonin, increased cytokines, and these cytokines are frequently released from the tumor. So pathogenesis again, the sensory input from the mouth influence the feeding behavior. That's why taste is a very important uh, sensation that correlates with the patient's symptoms, the extent of tumor involvement, and calorie intake. There are sensors present in the stomach and the GI tract, which also influences the quantity of food that is consumed, and any alteration in these sensors also is seen in cancer patients. There are also thermostatic sensors present in the GI tract that also tells us, based on the heat generated by the tumor, how much there is reduction in the food intake. There are glucose-sensitive receptors present in the brain and the liver, and it is possible that increased metabolism in the liver occurs in cancer that stimulates the hepatic receptors to cause a suppression of the appetite. Also, liposensitive and amino acid sensitive receptors, they also influence the normal food intake regulation. So there are multiple factors. So what is cancer cachexia? It is the destructive process that is characterized by skeletal muscle wasting and also abnormalities in the fat and carbohydrate metabolism despite an adequate calorie and nutrient intake. Cancer cachexia is different from just starving, that is starvation cachexia, because here there is equal mobilization of fat and skeletal muscle. The BMR is normal or increased. There is increased liver metabolic activity. There is increased glucose turnover, and there is increased protein breakdown, which is seen clinically as a loss of the skeletal muscle. So this is the spectrum of cachexia. Patients begin in a pre-cachectic phase where there's only weight loss, but then they soon progress into a cachexia syndrome where with weight loss there is systemic inflammation, reduced food intake, and then there is advanced cachexia where along with reduced food intake there's rapid fat depletion, severe muscle wasting, and also it affects the immune system of the patient, causes immunosuppression. Whether or not the patient progresses in this phase, in this type of spectrum from pre to cachexia to advanced, all depends on how successful we are in treating the underlying disease or in addressing the cachexia. So critical weight loss, as we know, is loss of 10% or more of the baseline body weight over a period of 6 months. So causes of cachexia can be metabolic, decrease intake, mechanical obstruction, increased loss, cytokine abnormality. So all these are the causes of it. The weight loss that is seen in cancer is also not directly related to just cachexia, but also many issues like psychological issues like anxiety, depression, fatigue, weakness. If the patient is in pain, even then they would not consume adequate diet. Treatment factors: chemotherapy induced nausea, vomiting, diarrhea, mucositis, dry mouth, which could be radiation therapy related, surgery from which there has been a prolonged post-op recovery. That also is one of the causes of weight loss. Mechanical obstruction, especially in head and neck and esophageal cancer, any bowel outlet obstruction, any metabolic changes like early satiety, delayed emptying, increased REE, this also leads to weight loss. So how is cancer cachexia different from a calorie deficiency? So this tells us in cancer-induced cachexia, there is significant increase in the protein degradation. This is the major difference between a cancer cachexia and calorie deficiency. And along with that, there's also an inflammatory state which is seen as increase in the acute phase reactants like CRP. There is decrease in the albumin. There is increase in the proteolysis inducing factor, and the end result is rapid skeletal muscle wasting. So these are the other observations that we seen in water, energy, lipid, carbohydrate, and proteins. So it's a vicious cycle where cancer chemotherapy causes malabsorption, anorexia because of the cancer leads to decreased food intake, pro-catechotic factors also come into play and causes decrease in the fat mass, decrease in the body mass, and the end result is cancer-associated cachexia syndrome. So body's response is in the form of cytokine production, and that cytokine causes a local as well as a systemic inflammatory response, and the result is increase in acute phase reactants and decrease in the appetite. The tumor also directly releases proteins like proteolysis inducing factor, which also causes loss of lean body mass. So the end result of this is weight loss, inflammation, fat depletion, muscle wasting, etc. So, how does it impact the clinical outcome? The impact is on the decrease in the body weight, because of which we are not able to give the adequate dose. It affects the tolerance to therapy. So again, that leads to decrease in the dose of the treatment, or sometimes even we have to interrupt the treatment or permanently discontinue it. It affects the quality of life, which is one of the very important patient-related outcome, especially in advanced malignancies, and also in the survival. It increases the weakness, increases the complications of the disease as well as the treatment, and makes the patient susceptible to infections. So, how do we assess the nutritional status? A careful history and physical examination is what we should begin with. Anthropometric examination in the form of checking the weight, BMI, the triceps, skin fold thickness, assessing the protein status by biochemical markers like serum albumin, transferrin, and then inflammatory markers like CRP, vitamin D levels, iron levels, B12, and folic acid levels. So the management involves nutritional counseling, where it is seen that early, intensive, individualized nutritional counseling, not one size fits all. Every patient requires different counseling. So this has been shown to preserve the body weight and the physical function, and also improve the outcomes of cancer therapy. And then we have pharmacological agents like corticosteroids, progesterone like megestrol, which increases the appetite. We have ghrelin, we have omega-3 fatty acids like EPA, which also has anti-caryptic effects. And we have BCAA, branched amino acid like leucine and arginine. We have nutritional supplements in the form of enteral or parenteral nutrition, which can provide as high as 25 to 30 kilocalories per kg per day. We have oral proteins in the form of supplements, which can provide 1 to 1.5 gram per kg per day of proteins. Now, where does Megestrol acetate come in this? So, Megestrol belongs to the group of appetite stimulant like medroxyprogesterone, also called MP. The clinical effect seen in randomized trials is there is an improvement in the appetite, the calorie intake, and the weight, but not lean body mass. The proposed mechanism of action is that Megestrol increases the central appetite stimulant neuropeptide. We also have cannabinoids, not easily available in our country. It is believed to act on the endorphin receptors and inhibits IL-1, and the end result is increase in appetite, but it has not been shown to improve the quality of life. So there are numerous dosages that have been studied in various trials, right from 480 to 800 to 1600 or also 240 mg per day. The major adverse effects of concern are edema. Sometimes very high doses like 800 or 1600 mg per day can even lead to thromboembolic events or DVT. However, if the dose comes down to a comfortable 160 or even 480, then no side effects or adverse events have been reported, and there has been sustained improvement in the quality of life across all the major trials that have been done and reported in this particular systematic review published in 2001. So this is one review where 35 trials were studied that comprised of 3963 patients for effectiveness and 3180 for safety. The conclusion of this systematic review was that Megestrol improves the appetite, and it results slight weight gain in patients not just having cancer but also AIDS and those who are having other underlying pathology. So this is another systematic review of Megestrol in treating anorexia cachexia that was published in 2004 in Journal of Pain. So as you can see, even in the subset analysis, there were more factors that were favoring Megestrol versus placebo. So even in another systematic review of Megestrol and anorexia syndrome, the conclusion was that there were few side effects associated with Megestrol, and Megestrol was seen as an effective and safe treatment for anorexia cachexia syndrome in cancer and AIDS patients, particularly when it comes to improving the appetite and the weight gain. So it has found its way in the ASCO guideline in 2020, where Megestrol is recommended at a suggested dose of 200 or to 600 mg per day. Liquid formulation is also there, maybe less expensive and more bioavailable than tablets. And the benefits are in improving appetite and slight weight gain. And the risks that we should keep in mind is edema, thromboembolism, and sometimes adrenal insufficiency. So this recommendation is based on the review of 23 randomized clinical trials of patients with cancer that totals to 3,400 patients, where it was seen that Megestrol acetate was more likely to work in patients in improving appetite. So, is Megestrol an effective treatment for patients even with terminal cancer? Then the answer is yes. It has been seen to lead to weight gain of around 2 kg even in patients with terminal cancer, and also improves the appetite. So, Megestrol is also included in the NCCN guidelines in the palliative care guideline, where patients who have low or no appetite may be prescribed Megestrol acetate between 200 to 600 mg per day, and that's where NDAS comes in. NDAS is what Samarth Life Sciences manufactures. We have all been familiar with NDAS right from our training days. So there was a study done between January to December 2019 to document the real life performance of NDAS in managing anorexia and cachexia cancer patients. They studied 443 patients between 18 to 90 years, so a good wide spectrum of patients between 27 to 90 kgs, equally distributed between males and females. So patients included were having various malignancies like breast, bladder, prostate, appendix, etc. across India. So this highlights the kind of patients that we normally attend to from major cities across India. Out of 443 patients, 7 patients expired, 5 in the follow-up and 2 after completing the therapy. So the recommended dose of Megestrol was minimum 160 mg per day. However, physicians were allowed to modify the dose as per the clinical judgment in the patient's condition. The dose ranged from as less as 40 to as high as 800 mg per day, and patients received minimum 1 month of therapy. And besides NDAs, they continue to receive the primary therapy for their cancer as well as other supportive care if required. So this core therapy was either radiation or chemo or target therapy depending on the disease. The primary endpoint of this study was improvement in appetite and weight gain. Secondary endpoint was safety. So patients were evaluated whenever they came for the successive cycles, either 1 week or 2 week or 3 week or 4 week, depending on what treatment they are on what regime of chemotherapy they are on. And every time the appetite improvement or deterioration was recorded as well as the patient's weight. So 81% of patients had an improvement in appetite. 56% of patients showed at least some weight gain. Uh, Improvement in the weight was seen almost 3.4 kg in patients who had a weekly cycle versus 1.9 for 2 weekly versus 1.5 in 3 weekly and 2.42 in 4 weekly cycles. 1% of patients reported side effects like nausea, diarrhea, ulcer, or hyperglycemia, but 99% did not have any major adverse effects. The physician, it was not just the patient, but also the physicians who gave a positive feedback in 94.6% cases. That reflects on the patient's the outcome and the tolerability. So these are the highlights of this study, and as you can see, NDAS had a good outcome even in our real world scenario of Indian patients. I think that brings my presentation to an end. Thank you very much. And if there are any questions, then I'll be more
Yeah.
than happy
Yeah.
to address them.
Thank you, Dr. Fahad. That was a excellent overview of the way patients are managed for anorexia and cachexia, and you really showed us the various pharmacological options that are available with us. So, just sir, one question from my side. Now that this is a drug which has been approved by various guidelines for whenever the patient has anorexia and cachexia. So we really want to know out of the patients who are all treated for cancer chemotherapy, maybe it's the so out of those, how many patients really need this appetite stimulants, and after how much period of time they really have to start taking this any of the pharmacological options available?
So in my practice, nutritional count, there is no, I would have to confess, there is no specific nutritional counseling for every patient, but of course we all check the patient's weight, examine and evaluate their general health, ask them about their appetite. So that way we do assess their nutritional status. My threshold, as I said in the beginning of my presentation, for NDIS is quite low. So the moment I feel that the patient is going to uh, experience low appetite or already has low appetite for some reason, either psychological problems or the drug that I'm giving is going to be too emetogenic, then I introduce it quite early, irrespective of what stage the patient is in, purely on the basis of their nutritional status. And even though it is there in the guidelines since quite some time, I feel that this drug is still underutilized because Medcase, besides the parameters that we saw in the trial, that is weight gain and appetite, I feel in my practice, because I've been using it extensively, there is also feeling of well-being. What we see in patients on steroids. So they have this feel-good factor, which eventually improves the compliance to the core therapy that the patient is on, and also that is one of the goals of therapy. The patient should feel good. Eventually whatever we are doing is for the patient to feel good, so that's where the quality of life comes in. So I think this is a very underutilized drug, and I frequently give it. In my practice, I would say 25 to 30 patients are on Megestrol at any given point of time, which is quite a lot.
Thank you, sir. Thanks. Thanks. So, if at all there are any questions in our chat boxes, we will really get back to you once if we have any
Yeah,
from the audiences who are watching the show. Yeah,
yeah.
Rajesh ji,
Dr.
anything? No?
Fahad,
Yeah.
yeah,
Yeah.
Dr. Fahad, Rajesh Mittal here, sir. Hello.
Hello, sir.
Yes, sir. How are you?
I'm good, thank you.
Yeah, yeah. Sir, one question from my side. As you said, this drug is underused. So, in the treatment like this anorexia and cachexia, there must be some other agents which are means replacing as NDAs, or maybe they are also being using. So, can you elaborate what are the other options which you feel like they must be using in most of these conditions?
So cyproterone is a drug which is used, which does not work, frankly. Cyproterone,
Okay,
at least not in cancer anorexia. It might work in other cases. And medroxyprogesterone, I think that is the other thing. But
correct.
I mean, I don't use it that often because I have not had that good results with patients on cyproterone. Besides that, occasionally antidepressants, antiemetics, olanzapine is also there, as you can see in one of the recommendations. Olanzapine is an excellent drug to control chemotherapy-induced nausea, vomiting specifically, but I don't think that really translates to increase appetite or weight gain if that's what we are looking at. So works in acute and delayed vomiting because of specifically because of chemotherapy uh, administration. And I think yeah, medroxyprogesterone and cyproterone is the other options that physicians opt for before progesterone.
Thank you, sir. Thanks for your.
Thank you, sir. So, again, let us continue with the presentation. So, I'll like to introduce the next speaker for the program today. So, I hope the slides are visible. Yeah. So again, it's my pleasure to welcome Dr. Asma Pathan, ma'am. So ma'am is a consultant medical oncologist at Indrayani Hospital and Cancer Institute, Pune. Madam has experience of working in various institutes and in Satara and Karad. She has been is a consultant has been a consultant in Life Care Hospital Panchgani at Satara. She has been associated with the Krishna Institute of Medical Sciences Karad and Omega Hospital Hyderabad as well, and Sahyadri Group of Hospitals from Pune. And she has been a consultant at Indrayani, presently a consultant in Indrayani Cancer Hospital. And also, ma'am has been a primary investigator in various clinical trials that also are ongoing as of now. And Dr. Asma has also published articles in various national and international journals. So I welcome Dr. Asma Patan again for the today's meeting, and I request her to share her insights on the topic of today. So over to Dr. Asma. You can start sharing the screen and stop here.
Good evening, everyone. First, I would like to thank Samarth Life Sciences for giving me opportunity to talk about this topic. My topic is my slides are
Yes. Slides are visible, ma'am.
okay. I'll be talking about the current treatment options in hormone positive and HER2 negative metastatic breast cancer patients. So coming to breast cancer, as we all know, breast cancer is the second most common cancer overall, and it's the most common cancer in women. And we see every year thousands of females die because of disease progression or failure of treatment. So although we have metastatic breast cancer is treatable, but it's the stage 4 breast cancer is incurable disease with the overall survival of only 3 years and a 5-year survival of only 25%. Coming to the epidemiology of breast cancer, worldwide, breast cancer accounts for 11.7% of the overall cancer cases. And in India, the scenario is 13.5% of all cancer cases belong to breast cancer. It is one of the most common cancer in females in India too, as per Globocon data 2020. It accounts for 26.3% of female cancer cases in India. And coming to types of breast cancer, we have different types of breast cancers. Molecular, we have estrogen positive breast cancer, human epidermal growth factor receptor positive breast cancer, and the cancer which doesn't have any of these types. So approximately in that 70% of breast cancer are hormone receptor positive and HER negative cases. So we will be discussing more about breast cancer, which is hormone positive and HER2 negative, especially metastatic breast cancer therapy in this discussion. So patients often respond to endocrine therapy alone or in combination with targeted therapy. Coming to the endocrine therapy, how we endocrine therapy means how we decrease the levels of hormones in these patients. So how to deplete estrogen in female patients? Initial therapy, we can go ahead with oophorectomy, the surgical one, or we can use medical sterilization with the use of luteinizing hormone releasing LH hormone agonist or antagonist. The other option is using aromatase inhibitors. The other strategies like hormonal agents are like selective ER modulators, which are tamoxifen or raloxifene, or selective ER down regulators, which is fulvestrant. The other targeted agents which can be used in these patients are cyclin-dependent kinase that are CDK4/6 inhibitors. We have in our basket palbociclib, ribociclib, and abemaciclib. The other agent is everolimus, which is a mTOR inhibitor. For those patients who have breast cancer patients who have PIK3CA mutations, we have a drug called alpelisib. Coming to how to, what is the management strategy for these HR positive, HER2 negative metastatic breast cancer patient, we'll go ahead with one by one, how we choose between different types of chemotherapy. Choosing between endocrine therapy and the chemotherapy. So first is endocrine therapy is preferred because it is less toxic and easily given to the patient. Patient can take the medicine at home because it is in an oral formation. Chemotherapy is only reserved for patients who are refractory to endocrine therapy or who have extensive symptomatic visceral involvement. When the patient is in visceral crisis, we go ahead with chemotherapy. And chemotherapy as first line, many minority of patients with extensive visceral metastasis, where there is evidence of end organ dysfunction, we go for chemotherapy. Otherwise, the patients are put on endocrine therapy. After progression of second line of endocrine therapy, treatment is based on prior treatment response and tumor burden and as per the individual preferences. There are no data that combines ET with chemotherapy, which improves survival, or therefore we do not use these strategies together. What are the considerations for those who received adjuvant ET? A woman who progresses more than 12 months from the end of adjuvant ET, we offer them first line endocrine therapy or endocrine therapy in combination with CDK4/6 inhibitors. If they are affordable, we go ahead with, now we have a generic palbociclib, we can go ahead with palbociclib. We have other options also, CDK4 inhibitors, like new other ones, ribociclib or abemaciclib. And woman who progresses on or within 12 months of completing adjuvant ET, for them also subsequent second line of ET or ET in combination targeted agents are given. Patient who progress on first line ET for a metastatic disease, then we go ahead with the second line treatment. Coming to preferred first line chemotherapeutic line therapies. Preferred first line therapy will be aromatase inhibitors plus CDK4/6 inhibitors. Woman who progresses within at least 12 months after the end of adjuvant ET and patient who present with de novo metastatic breast cancer patients, we offer them CDK4 inhibitors plus aromatase inhibitors. And if the patient is premenopausal woman, we must have to make them postmenopausal by using either ovarian suppression or ablation when we have to add AI. These are the trials which showed, these are the trials showing the response rate with aromatase inhibitors plus palbociclib, that is Paloma 2 trial. In that, there was a response rate of 43% when palbociclib with letrozole was used. And it was the overall survival was 53.9 months as compared to placebo with letrozole, that was 51.2 months. So in previously untreated ER positive, HER2 negative advanced breast cancer, palbociclib combined with letrozole has resulted in a significantly longer PFS than with letrozole alone. The other agent we have is ribociclib. Even we can use that with AI as a first line treatment in a MBC or after failure of endocrine therapy. And that has given a response rate of around 43% and overall survival of 63.9 months compared to placebo with letrozole of only 51.4 months. The third agent is abemaciclib. Even this has given an overall survival benefit too in cases with MBC. All these three agents are available, and the differences in their which to be chosen depends upon patient's financial capacity as well as the side effect profile of these three drugs. So how do we choose these drugs between the three? For choosing between palbociclib versus ribociclib, both have resulted in a similar overall response rate and PFS and similar toxicities, but only thing with ribociclib is it has more chances of QTC prolongation compared to the palbociclib. And as we compare palbociclib with abemaciclib has more chances of diarrhea compared to palbociclib. So these are the different side effect profile and their half-life of 3 CDK4/6 inhibitors. Palbociclib has a half-life of 29 hours. Ribo has 32 and Abema has 18.5. The side effect difference is myelosuppression is seen with palbo and ribociclib, not much with abemaciclib. And QTC prolongation is seen with ribociclib. So we have to monitor the ECG when we have to check out the ECG before starting the drug, and even we have to monitor the patient with the ECGs for QTC prolongation. And the more problem seen with Abema is the diarrhea, which responds later, but as it targets most of the CDK receptors, so it causes loose motions. So as per the patient's profile, we have to choose the CDK4/6 inhibitors. Financially also, this ribociclib and abemaciclib are the costly drugs. Palbociclib, we have an Indian version, so we can go ahead with the Indian version of palbociclib. Coming to choosing between different AIs, no one AI is better than the other. In a trial of advanced breast cancer, exemestane and anastrozole resulted in a similar overall response rate and OS. So we can use any of the AIs, but as we are using, we use letrozole more commonly because data has suggested letrozole is more effective AI as compared to others. Coming to alternative frontline options, when we don't have CDK4 inhibitors, patient cannot afford CDK4 inhibitors before. Now we have a generic version of palbociclib, so we are able to use that. But when we don't have those drugs, so what are the first option for first option? So we can use fulvestrant monotherapy, or we can use fulvestrant monotherapy along with AI. That is shown in a Falcon trial. The outcome was better. It was like median follow-up of 25 months. We had a good response with the fulvestrant with AI as well as without AI. Coming to other option, like once a patient progresses on AI with CDK4 inhibitors, we can go ahead with the second line of anti-hormonal therapy, that is fulvestrant plus CDK4 inhibitors. Even that has given a good response rates and a PFS. When we use fulvestrant with palbociclib, which was compared with letrozole with palbociclib in a randomized trial of 486 patients who were previously treatment naive, there was PFS, median PFS was 27.9 months versus 32.8 months respectively at a difference that was not statistically significant. Coming to subsequent line of options, woman who progresses on adjuvant ET or within 12 months of completion or progresses on first line treatment for metastatic disease, we can go ahead with further testing for the patient. Either we can add on fulvestrant with CDK inhibitor, or we have to check for the other mutations in a patient. We have to check for PIK3CA mutations. If the patient is wild type, if there is no mutation, for fulvestrant monotherapy or everolimus based combination can be used. If the patient has PIK3 mutation, then fulvestrant with alpelisib can be used. For those with progression on previous tamoxifen, AI plus CDK4 inhibitor are used. If a patient is premenopausal, she should have undergo ovarian suppression or should have ovarian ablation before receiving the aromatase inhibitors. This is Paloma 3 trial where they use fulvestrant with palbociclib. It was used in a patient who had progressed on endocrine therapy, which showed a significant improvement in the patient's progression-free survival. This Monarch trial is Monarch 2 is trial where they use abemaciclib instead of palbociclib. Even that showed a good response. And in the Mona Lisa 3 trial, they showed a response rate using fulvestrant with ribociclib. For those previously treated with an AI plus CDK4/6 inhibitor, we have to check for this, as I said, PIK3 mutations. If it is wild type, we can go ahead with fulvestrant with or without everolimus. Alternative to fulvestrant is we can use everolimus with AI or everolimus plus tamoxifen, but everolimus is a very toxic drug, very difficult to use. So usually we put the patient on either AI or tamoxifen. And in cases with the PIK3CA mutated cases, we use alpelisib. Even that is a very toxic drug which causes a lot of hyperglycemia and all. So usually difficult to use such drugs. Coming to later line of therapy, later we have different, when a patient progresses on multiple lines of endocrine therapy, we go ahead with chemotherapy, different lines of chemotherapy. We use gemcitabine, carboplatin, we use venerolabine, we can use eribulin in the later stages. And we have new drugs into the market. These are antibody drug conjugates. Sacituzumab govitecan, it's an anti-TROP2 antibody drug conjugate, which is used in hormone positive and HER2 negative cancer patients after prior treatment, including endocrine therapy, CDK inhibitors, or at least 2 lines of chemotherapy have been failed. Such cases, they have been like this drug has been used, not yet into the market, Indian market. And the other drug is trastuzumab deruxtecan. Even that is being used in HR positive, HER2 1 plus or 2 plus cases. When we don't have anything, then patient is put on either tamoxifen, if they are affordable with abemaciclib. If they are not affordable, just a tamoxifen or some other hormones, patient will be put on other lines. Additional consideration, as I told you, in premenopausal women, we have to suppress their ovaries using either surgery or some other drugs. And in some cases who are like breast cancer cases who are BRCA mutated, we can use anti-BRCA, this thing, olaparib and all, if they are positive for BRCA. There are so many research going on novel ACRDs, and they are even trying, many trials are going on using ET plus ER blockade. Thank you.
Thank you, Dr. Asma. Thank you, Dr. Asma. That was a wonderful topic. You covered many things in such a short period of time. So, since you have mentioned so many different options available after the first line, the second line, and third line, so I had just one question for you.
Yes.
Nowadays, this chimeric antigen receptor T cell therapy, now it's becoming more established as an option for various hematological malignancies.
Yes.
So are people opting this for solid tumors? And if yes, then what about its usage in breast cancer, and which type of breast cancers?
I don't have much idea about it, but there are trials going on in lymphomas, multiple myelomas, for these cells, CAR T cells. So even Tata is doing so many trials along with our IIT people using these chimeric antibodies for it's more in blood cancers like lymphomas.
Okay.
Not
Okay.
breast cancer. I think it's still in a
very the reason why it triggered me is because the HR positive, HER negative, this ER positive and HER negative, they are the commonest ones, as you rightly mentioned.
Yeah,
but
70% of cases are those.
Yeah, but then what about those cancers which are triple negative? Means they don't express this estrogen receptors, they don't express the HER receptors.
That is a very difficult cancer to be treated. Usually, triple negative cancer, it occurs in a very young ladies, especially like 30 to 40 age group. And it is like we don't have much option in them, because at least when we have a target, we target them. When we have ER positive, we can use hormonal therapy, we can use CDK4 inhibitors. But in a triple negative breast cancer, we have only chemotherapy.
And now, only chemotherapy. So
So
could this be
very
an option?
Yes, they are doing so many trials in TNBC cases because it's hurting the young people. It's causing a lot of damage to the younger generation. So they are doing so many trials, many drugs one by one. They are in pipeline now. So these drug conjugates, many drug conjugates are into the market now. So in a
Okay.
triple negative cases, they yet to come. There are many trials going on in breast cancer cases, especially HER2 positive and triple negative cases.
So that's all from my side. Thank you so much, Dr. Asma. So a wonderful session. In short time, Madam has covered most of the things. So thank you, Dr. Asma, for joining us for today. So as we come to the end of the medical topics for today, I hand over it to Geeta Shri, who is my counterpart from the marketing team, to conclude this uh, day for today about the CME, and then we can all disperse. Geeta, are you there?
Yes,
Yeah,
I'm
Thank
there.
yeah.
you.
Over to you, please.
Yes, ma'am. Uh, Thank you, Asma ma'am, and thank you for Abdul sir, for joining our session. And thank you, for your time, expertise, and contribution for this webinar. Your presentation and responses, which you have given, it's a great clarity and depth of the topic, making a webinar very informative and impactful, ma'am and sir. Thank you so much for joining, and thank you, Dr. Sanjay Kamble sir, for taking the session all over this, because you were also busy, but you took a time and took a session. Thank you so much, and all the attendees which are attending this webinar. Thank you so much for your time and joining the session. Thank you.